We're creatures of habit in the OR. Everything we do has rhythm, protocol, and purpose. You prep your room, double-check the preference cards, run the count, confirm the patient, and move. Fast, but never rushed. Efficient, but never sloppy. There's comfort in that precision. It's how we keep people alive. I've been in the operating room for over 17 years, mostly general, some trauma, some neuro, and I floated vascular for a while. Our hospital's main OR has 12 rooms, 12 engines that run non-stop from 6 a.m. to after midnight some days, especially when we get backed up with emergencies. You don't get through that grind unless you respect the structure. We keep things tight. Scrub techs prep trays, circulators check consents, anesthesia rolls in early, and surgeons, well, the good ones show up just in time for timeout. Everyone has a role, and everyone depends on everyone else. Mistakes cost blood. Distractions aren't tolerated. That's why what I'm about to tell you stuck with us. It didn't break protocol, but it slipped past it, and nobody could explain how. It started with a scrub cap. Nothing dramatic, just a faded blue cotton cap with white embroidery stitched on the band. RJ8, simple block letters, slightly frayed at the seams. Most OR nurses can recognize a surgeon by their cap. Some wear wild patterns, others wear disposable ones with Sharpie scribbles. But that cap, everyone in our unit recognized it. It used to belong to Dr. Robert J. Halperin. He was one of ours, cardiothoracic, not flashy, not soft. He was demanding, sharp, and focused. Worked clean. You didn't mess around when he was on the board. He passed away 2 years ago. Massive MI at home. Didn't make it to the cath lab. It hit the team hard, even the ones who pretended it didn't. After his death, we boxed up his things from the locker room, cleaned out his cubby, and had a small ceremony in OR3 where he did most of his cab jazz. A moment of silence. Tissue bank donation. Acknowledgement. His caps were given to his family, or at least we thought they were. Fast forward to a Tuesday morning, typical elective cases. We were prepping for a laparoscopic cholecystectomy in OR2. I was the circulating nurse. My scrub tech, Denise, pulls her gear from the clean linen bin outside the locker room. She stops cold, holds up a blue cap, and says, "Is this?" Sure enough, RJH, same stitching, same wear pattern, same faded band. We all just kind of stared at it. I told her maybe it was an old one that somehow got mixed back in. Housekeeping does laundry pickups twice a day. Maybe a staff member found it and tossed it in the wrong bin. Denise didn't wear it, just folded it and left it on the supply cart. Next week, Wednesday, another cap. Same bin, same cap. We pulled the linen logs. No cap like that was turned in. We even checked the system to see if someone added a scrub cap to the OR requisitions. Nothing. We started bagging the cap each time it showed up, marked it with the date, logged who found it, and put it aside. It came back, washed, folded, tucked into the clean pile. No one admitted to putting it there. Sterile processing denied it came through their station. Housekeeping swore it wasn't from their side. By week 3, it wasn't just OR2. Someone found it in OR3. Again. Here's the thing. OR3 was Dr. Halperin's preferred room. It's where he did nearly every valve replacement, bypass, and dissection. He had his routines, how he wanted his Mayo stand, which clamp he'd ask for before the PA could even reach for it. He ran that room like a general on campaign. At first I thought maybe someone was messing around, a joke, maybe even something morbid out of sentiment. Nurses do that sometimes. We process grief in odd ways. But when we checked badge access for the linen room overnight, there was no unauthorized entry. Just the usual night shift reset. The cap kept returning. One day I finally put it in a sealed plastic bag, wrote a note, and left it with the nurse manager. She's meticulous, logs everything. She placed it in her office drawer. It never came back, until the next Monday. Clean bin, same cap, freshly laundered, same initials. At this point, even the skeptics were talking. We had a short huddle. The manager went to her office, opened the drawer. Her sealed bag with the cap inside was untouched, which meant the cap that showed up wasn't the one we'd stored. We have no logical explanation, and no one's trying to turn this into a ghost story. This isn't about hauntings or chills or shadowy figures in the OR. Nothing moved on its own. No machines malfunctioned. No alarms went off without cause. Just a cap. Quiet, clean, placed where it didn't belong. But I'll say this, when that cap shows up, we don't throw it away. We place it gently on the shelf beside the locker room door. We nod. We keep working. Out of habit, out of respect, out of something none of us have the words for. Because in this field, you don't always get closure. You just get through your shift, support your team, and honor those who came before you, even if it's just with a simple cotton cap that keeps finding its way back. Hello friends, and thank you so much for tuning in. A special shout out to our incredible subscribers. Your support keeps these creepy, fascinating, and sometimes even comforting stories alive. But here's something to think about. Only about 30% of our viewers are subscribed. If you enjoy our content, hitting that subscribe button helps more than you might realize. It only takes a second, but it makes a world of difference. While you're at it, a like and share go a long way in keeping these eerie tales coming. Thank you again for being part of this journey. You're the reason we're here. See you in the next one, if you dare. You get used to stress in the OR. That tight timeline between incision and closure, the weight of sterile fields, the hum of suction and cautery, and the way time seems to both slow down and race at the same time. What you don't get used to, what no one ever really adjusts to, are the anomalies, the things that don't belong in the equation. That day started off standard. It was a Tuesday, second case of the day, scheduled at 10:30 a.m., a routine left total knee replacement. We'd done hundreds of them, maybe thousands, if you include all the surgeons over the years. Or 4 was assigned. It's one of our older rooms, slightly colder, a bit more echo than the newer suites, but well equipped and compliant. The patient was a 72-year-old male. History of osteoarthritis, BMI in the normal range, cleared by anesthesia pre-op the day before, prepped and marked, consent signed, labs normal, nothing flagged. I was the circulating nurse. Jen was scrubbing, anesthesia was Dr. Nguyen, and the ortho attending was Dr. Caro, a no-nonsense methodical surgeon who didn't tolerate delays. We prepped the field, verified the count, and started on time. Tourniquet, inflated. Timeout complete. Everything by the book. About 20 minutes in, just as Dr. Caro was finishing the femoral prep and moving toward the tibial cut, I felt a warmth in my left nostril, reached up instinctively, and sure enough, blood, nosebleed. Now, I don't get nosebleeds. Not from heat, not from dryness, not even during winter shifts when the hospital air gets bone dry. Still, I stepped out, pinched it off, got it under control in under 2 minutes. Didn't think much of it. Mask swap, re-scrub, back in. 5 minutes later, Jen, my scrub, asked for a tissue. I looked over. Blood was dripping under her mask. Slow, steady centerline bleed. I helped relieve her and scrubbed in a replacement. She was embarrassed, said she hadn't had a nosebleed since middle school. Then Dr. Nguyen, our anesthesiologist, let out a low curse. Same thing. He had to step back from the head of the bed. Slight trickle coming from his right nostril. Not heavy, but enough to startle us. 3 people, in the same room, within minutes of each other. We paused briefly, just enough to log the incidents in the intraoperative note. Patient remained stable. BP was fine. No signs of infection, or adverse reaction. Or manager called in to observe. Nothing unusual in the air. No vaporized meds. No odd smells. We kept going. 10 minutes before closure, we called for plastics to assist with skin approximation. While standing off to the side of the field, our surgical assistant, Kyle, who hadn't moved from his spot by the back table, raised a gloved hand and said, "You've got to be kidding me." Another nosebleed. That made 4 of us, all in the same procedure. By then we'd ruled out dry air, chemical exposure, even checked the gas lines. No leaks, no oxidizers, no weird compounds. Or 4 didn't use nitric oxide, or anything high risk. And still 4 healthy staff members had spontaneous, unexplained nosebleeds, all within about 40 minutes of one another. Patient was stable throughout closure anesthesia. Report was normal. Transfer to PACU was smooth. But around 9:40 p.m. that night, we got the call. He coded on the med-surg floor. Pulmonary embolism. Sudden, massive, unrecoverable. We all heard about it the next morning in huddle. The charge nurse paused and said, "That was the guy from OR4 yesterday, right?" "Yeah, he was. Here's what makes it worse. That was the only fatality we'd had from a routine TKR in over 5 years. The next day, I requested to float to OR2. I didn't want to go back in that room. And I wasn't alone. For almost a week, no one wanted to scrub in OR4. Not unless they had to. There was nothing visibly wrong with it. Equipment tested fine. Airflow was within spec. Temps normal. Nothing traceable in the environmentals. But no one forgot it. and that cap from infection control that shows up quarterly to talk about surgical hygiene. She came through 2 days later, asked if we'd had any unexplained contamination incidents recently. She'd heard a rumor from PACU. We told her the story. Straight. No embellishments. 4 nosebleeds, 1 death, 1 room, 1 case. She didn't say much, just took her notes, thanked us, and walked out quietly. Since then, we've run dozens of cases in OR4. Nothing else has happened. No more nosebleeds, no strange events, but we all remember. Every nurse who was in that room remembers. And sometimes when you're reviewing the schedule and see OR4 listed beside your name, your stomach drops a little. You tell yourself it was a fluke, that things happen, that medicine has margins. But in the back of your mind you still wonder, why that day? Why that room? Why that patient? And why did it only happen once? Surgery is about control, controlled chaos, sure, but still control. That's what draws most of us to the OR, in the first place. You know your role, you follow the protocols, and you lean into the structure. It's not like med-surg or ICU, where things evolve hour by hour. In the OR, time is sliced into cases. You prep, execute, recover, and move on. But PACU is the in-between. The soft landing between anesthesia and wakefulness. It's where the lines blur a little. In our hospital, the PACU sits just beyond the red line threshold from the OR. 8 bays, semi-private, with thick fabric dividers, low lighting, and a hum of machines and vital monitors that never quite fade into the background. No windows, just wall clocks, curtain hooks, and the smell of antiseptic, mixed with warm blankets and propofol. You spend enough years in that room, and your body starts to adjust to the silence of it. I've been a circulator for years, worked trauma, vascular, ortho, and float. But I often jump into PACU when they're short, usually for second shift. That's when things slow down a bit. The scheduled cases are done, and you're just waiting for the last patient to extubate, stabilize, and either move to a bed or be wheeled out to family. It's the quietest part of the surgical cycle, and sometimes that quiet lets things through. It started during a routine late shift, Friday. I remember because I had plans to meet my sister after work and was checking the clock every 20 minutes. PACU was running with minimal staff, Rachel, Emma, and me. We had 3 patients recovering, 1 general surgery, 1 hysterectomy, and 1 laparoscopic cholecystectomy. All stable, all adults. Our unit hadn't received a PEDS case in almost 3 years, not since the new pediatric tower opened 5 miles away. It was about 4:40 p.m. I was at the nurse station logging vitals into Epic. Rachel was tidying the crash cart near Bay 7, and Emma had stepped out to grab a sandwich. That's when Rachel stopped mid-step, looked toward the end of the unit, and froze. "You see that?" she asked, voice flat. I turned, expecting to see transport. Instead, the hall was empty. Rachel slowly walked down the stretch toward Bay 8, then pulled back the curtain. Nothing. She checked Bay 6. Still nothing. Then she came back to the station, pale. "I swear I just saw a kid," she said. "Barefoot, just walked from 8 to 6. Head down, looked like a little boy." We didn't say much more. Just one of those weird things you chalk up to fatigue. Long shifts can play tricks. Your brain fills in movement where there isn't any. But then 10 minutes later, Emma returned. First thing out of her mouth, "Why was there a child standing near Bay 3? Rachel and I both turned. "What child?" She looked confused. "Little boy. Dark hair, pale, just standing there. I saw him from the hallway." We walked to Bay 3, pulled back the curtain. Empty. No patients had been in Bay 3 all day. Charts confirmed it. Emma looked visibly shaken, but we kept our composure. We have to. Patients are always listening, even when you think they're still under. You don't talk about ghosts or hallucinations in PACU. You talk about BP trends and oxygen saturation. Still, we called security. Standard procedure for unidentified persons in a clinical zone. They checked the badge reader logs, hallway cameras, entry points. Nothing. No sign of a child. No unauthorized access. They even walked the perimeter and checked the family waiting area. All clear. Housekeeping came through later that night to do final cleanup before weekend operations. The lead tech, Marcella, casually asked us, "Hey, did someone's kid drop this?" She held up a small plastic figurine, an army man. No one had seen it before. No one had dropped it. It wasn't from a patient bag. Not adult related. No toys allowed in PACU. not even for visitors, which we hadn't had that shift. We started watching, quietly. Over the next few weeks it happened again. Not every day, but enough. Rachel caught a glimpse of someone ducking behind a curtain. Emma said she heard light footsteps, barefoot, fast, just before turning the corner near Bay 5. I saw what looked like a shadow cross from Bay 1 to Bay 2, even though we had only one patient recovering in Bay 7 at the time. We checked the linen logs, the housekeeping reports. Everything was clean, controlled. On paper, nothing was wrong. Then Denise, one of our new nurses, prepped Bay 6 for a late surgical recovery, and paused. I was across the hall when I heard her say, can someone come look at this? She pointed to the inside of the privacy curtain. A tiny handprint, palm-sized, right at knee height. A perfect smudge, slightly oily, like it came from skin. But no patients had been assigned to Bay 6 for 2 days, and housekeeping had signed off on it as terminally cleaned. Denise cleaned it off herself. No fuss, no report, just another unexplainable moment. We chose not to escalate. Then came the part that changed it for me. It was just past 6 p.m. A transport aide came in to pick up a post-op patient from Bay 4. We were short-staffed, so I helped prep the transfer. Patient was still groggy but alert. As we rolled out toward the double doors, the patient mumbled something that made me stop. "Where's the little boy?" I asked her to clarify. She was slow with her words, still under the effects of anesthesia, but she repeated it. There was a little boy, standing at the end of the bed. I thought he was with a nurse. That patient had been under general anesthesia for a 2-hour procedure, fully intubated, never out of our sight. We didn't tell her anything else. We just noted it and got her settled. After that, we started keeping Bay 3 and Bay 6 open whenever possible. Not for any medical reason, just out of courtesy to whatever was passing through, not out of fear, not even superstition. Just a quiet agreement among staff. We don't know who he was, or what he was, or why he seems tied to our PACU, which hasn't handled a child in years. But we know what we've seen, we know what we've heard, and in a place where so much of what we do is science, sometimes, you don't get answers. You just stand in the in-between, same as the patients, same as the child, and wait. There's a rhythm to pre-op, especially when you've been doing this for years. You walk into pre-op holding, clipboard in hand, gown rustling, hair covered, face masked. Introduce yourself. Verify name and date of birth. Confirm consent. Review the chart. Start the IV. Keep things light if you can. Joke about warm blankets. Ask what kind of music they want in the OR. You learn to read the room. Some patients want silence. Some want reassurance. Some pretend not to be scared. That morning was a Wednesday. I remember because I'd picked up an extra shift. It was still early, barely 7 o'clock a.m., and we were starting with light procedures. First on the board, a 54-year-old woman scheduled for a laparoscopic ovarian cystectomy. Not even a full oophorectomy. She was healthy, vitals steady, no cardiac history, non-smoker, BMI in the normal range, EKG clean, blood work cleared by anesthesia 2 days prior. I found her in Bay 2, already in her gown, saline, running, legs crossed under a heated blanket. She looked calm, not sleepy, not agitated, just still. I introduced myself like I always do. "Hi, I'm your OR nurse. I'll be with you before and after surgery. How are you feeling this morning?" She looked at me for a second, then smiled a little and said, "I'm okay, but I don't think I'll be coming back." It was quiet when she said it. No drama, no tears, just a fact. I paused. I thought maybe she was talking about recovery. Maybe she meant she didn't want to return for a second procedure, or she hated hospitals. I asked, gently, "What do you mean?" She looked me dead in the eyes and said, "Something about today feels wrong. I don't think I'll be leaving this hospital. I've had patients joke nervously before. Take good care of me, or I hope I wake up." But this wasn't that. Her tone was flat, resigned. I sat beside her for a second longer than I usually would. "You're in good hands," I told her. "We do dozens of these procedures a month. You're healthy. Everything looks great." She nodded. "I know, but it's not the surgery. It's something else. I don't know how to explain it." Before I could say anything more, anesthesia arrived. Dr. Barlow, experienced, thorough. He didn't rush patients. He reviewed her chart, asked his questions, walked through the induction plan. She answered everything, calm, cooperative, never hesitated. But as we wheeled her down the hall, she glanced over her shoulder once and whispered, "Thank you." Not the usual kind of thank you. It sounded final. Or 5 was prepped and ready. Standard laparoscopic setup, scope tower, insufflator, cautery, backup suction. Jen scrubbed in. I confirmed timeout. Instruments counted. Everything was routine. She was still talking calmly with anesthesia as they placed the mask and started induction. She wasn't anxious, didn't flinch, didn't cry, just breathed like she'd done this before. Then her sats dropped. Fast. I looked up at the monitor. 92, 85, 79, within seconds. Doctor. Barlow called for bagging, then airway support. BP tanked. We started chest compressions, less than a minute later. No laryngospasm, no aspiration, no known allergy, no signs of anaphylaxis. Crash cart was pulled. Code was called. She never regained a rhythm. We coded her for nearly 40 minutes. Full team, ACLS protocol, everything we could. She was pronounced at 8:13 a.m. It wasn't the surgery. It wasn't the anesthesia. Autopsy later showed an undiagnosed ascending aortic dissection. Rare, silent, catastrophic. No imaging had shown it. She never reported pain. The surgeon was shaken. We all were. Afterwards I walked back to Bay 2 to clean up her area. Her belongings were still neatly folded in the bedside bin. Shoes lined up perfectly. Phone charger coiled tight. A paperback book titled Peaceful Transitions. I sat down for a moment, on the edge of the bed. Just sat. The curtain was half drawn. Morning light from the OR hallway spilled in, and the space felt still. I kept hearing her words. I don't think I'll be coming back. We don't write those things in charts. We don't mention it in the post-op debrief. There's no checkbox for patient predicted death. But we remember. And in the quiet moments between cases, when the room's empty and the drapes haven't been hung yet, I still think of her. Not out of fear. Not even out of sadness, though there's plenty of that. But because sometimes, very rarely, patients seem to know something we don't. And when they tell us, we should listen. Even if we can't understand it. Even if there's nothing we can do. We still owe them that much. Thank you so much for watching and being part of this growing community. Your support means the world to us, and it's what keeps these creepy, fascinating, and sometimes comforting stories alive. We'd love to hear from you. If you've experienced something eerie, unexplained, or deeply moving, feel free to share your own story in the comments below. You never know, your story might be the next one featured. And if you haven't already, don't forget to subscribe, like, and share to help keep the chills coming. We couldn't do this without you. See you in the next one.